Shall I introduce myself?
Yes, ma'am.
I'm Dr. Vijaya Manohar, working in Apollo Cradle, Kormangla. I'll be talking on I'm a consultant in obstetrics and gynecology, and I'll be talking on abnormal uterine bleeding. So, to know about abnormal uterine bleeding, we should know about the normal menstruation. No, the normal cycles are once in 28 days, and the flow lasting for 3 to 6 days, and it is cyclical in nature and regular, and it may vary from 21 to 35 days. So, regarding the abnormal uterine bleeding, so the flow will be for longer duration, and the amount of the duration of flow also will increase, and there may be intermenstrual bleeding, and they can have bleeding after menopause also. So these are the things for the abnormal uterine bleeding. Longer the duration, heavier the flow, irregular periods, like once in 21, less than 21 days or more than 35 days, and intermenstrual bleeding, and any bleeding after menopause, all causes abnormal uterine bleeding. So to know the reasons and the causes for abnormal uterine bleeding, we have some causes like polyps, endometrial carcinoma, then malignancy, then fibroids, adenomyosis, and other causes like coagulation disorders and endometriosis and hormonal imbalance, which is the commonest in like polycystic ovary. And other unclassified causes are the bleeding can be related to intrauterine contraceptive device, on medication like oral pills, stress, obesity. These are the other non-classified causes for abnormal uterine bleeding. So coming to the polyp is nothing but a thickened endometrial tissue where there may be it may be attached to the cavity by a thin pedicle, or it may have a broader base. So these are called as the polyps. That is nothing but thickened endometrial tissue attached to the cavity either by a thin pedicle or by broader base. Next is the adenomyosis, where the endometrial glands grow into the myometrium, where it can cause heavy bleeding, intermenstrual bleeding, dyspareunia, dysmenorrhea, and that. So this adenomyosis uterus will be slightly enlarged with thick endometrium and heavy flow with intermenstrual bleeding. The third common cause will be the fibroids. Fibroids are usually the growth arising from the uterine wall. They are multiple in nature, small to large. They usually the larger fibroid and also a submucous fibroid causes heavy bleeding. The fourth common will be the malignancy. That could be endometrial cancer, endometrial hyperplasia. These are the four common causes: polyps, adenomyosis, fibroids, and malignancy. The other causes are the coagulation disorder, where there may be causing a heavy bleeding, and other endometriosis. And the third cause will be the hormonal imbalance, endocrine dysfunction. That is common, which is seen in polycystic ovary. And the other rare non-classified causes are the obesity, stress, and IUC. Patient with IUCD can also have abnormal bleeding. So these are the some of the causes for both. We call it as this abnormal bleeding. We can be due to the organic causes and also the non-classified, the coagulation disorders, endocrine dysfunction, endometriosis, stress-related, obesity, IUCD-induced bleeding. So how to proceed with the case? The proceed with the case, detailed history exam. History is very important. The intake of medicines, and also the regular regarding the menstruation, we should take a detailed the regular cycles, heavy flow, whether it is the duration of the flow, and whether she is on any oral contraceptive or any other medications, whether she has any IUCD inserted. So history is very important. Coming to the examination part, so general examination looking for anemia, and also the risk factors like obesity, hypertension also should be left in the general examination. And local examination, we have to go for per speculum and per vaginal examination. Speculum to rule out any local causes, the vaginal examination by manual examination to look for the uterus size, the mobility, the fixity, any tenderness in the fornices, enlarged uterus, that should be looked for. Coming to the investigation part of it, The common investigations what we do when a patient comes with abnormal uterine bleeding, complete blood count and hormone profile also should be checked. Suspected like for PCOD, we go for a FSH, LH, prolactin, and thyroid profile is also checked. And sometimes the abnormal bleeding can be related to pregnancy issues, which the history may not reveal. So better to go for a pregnancy test. Suspected cases, we can go for a HCG, the blood test, and thyroid profile, hormones, complete blood count, blood grouping, routine blood sugar, all that has to be done. The next part of investigation will be the pelvic ultrasound. The ultrasound will tell us about the enlargement of the uterus, any fibroids, polyps, ovarian pathology, endometrial thickness, especially in the menopausal age. The cutoff we take it as 4 mm as the endometrial thickness. Any postmenopausal bleeding, if the endometrial thickness is more, we should have a further investigations. So the next, the ultrasound is an important tool in investigating abnormal uterine bleeding, diagnosing polyps, fibroids, then adenomyosis, the endometrial thickness, and adnexal pathology. All that we can rule out by ultrasound. The next part of investigation, any suspected polyps, we have to go for a hysteroscopic evaluation. So hysteroscopy is an important diagnosis in diagnosing a polyp. The next is the endometrial biopsy. So when we do the endometrial biopsy, whenever there is an abnormal uterine bleeding, the age being more than 45 years and not controlled with the conventional progesterone therapy, we have to go for a diagnostic DNC. That is to rule out endometrial pathology, and also it sometimes it will be both diagnostic and therapeutic. It might stop the heavy bleeding, and also diagnostic, we will know the abnormal pathology like endometrial hyperplasia, atypical hyperplasia, suspected cases, endometrial cancer can be diagnosed. Then these are the important investigations. Right from the blood counts, then go for this thing. Ultrasound is an important. Then hysteroscopy to in suspected cases of polyps. Then endometrial biopsy in cases where there is no control with the bleeding. No, so we have to go for an endometrial biopsy. So regarding the management, the common what we start with is the tranexamic acid, which are non-hormonal. So patient acceptance will be good, and we try with the progesterone. Like, I mean, the non-tranexamic acid 500 mg 3 times for 5 days, and sometimes we have to add with progesterone tablets, the various progesterone, norethistérone, norethindrone, medroxyprogesterone, micronine. Any progesterone can be given depending upon the patient condition. So we give a course for progesterone therapy for 2 to 3 months, and sometimes depending on the age and the findings, we put them on oral contraceptives for 2 to 3 cycles. And if there is no improvement further in cases of adenomyosis and all, we have to think of giving this thing, no, the Marina insertion, that is a levonorgestrel, locally acting progesterone. It is acceptable. We can, this is a good improvement with the levonorgestrel, that is a Marina. It's an IUD insertion in the, depending upon the pelvic ultrasound and the patient acceptance, and we have to decide the management. So next, coming to, if there is a suspected polyp, if the polyp is diagnosed, hysteroscopic removal of polypectomy, that is called as polypectomy. And next will be the fibroids. Fibroids asymptomatic, no need any treatment. If there is a large fibroid, especially, and if there is a submucous fibroid causing heavy menstrual flow, we have to go for, depending upon the patient desire for fertility. If they want to preserve the fertility, we have to go for only myomectomy. And if the patient has finished her family, if there is a large fibroid and not large fibroid with heavy flow, if the age is more than 45, we have to go for, if the fertility is completed, then no desire for fertility, then we have to plan for hysterectomy. As we know, hysterectomy can be done more vaginal and also by abdominal no, laparoscopic abdominal hysterectomy. So then other small, other factors like the lifestyle changes, like reducing the obesity and also stress, all the other factors which will also help in controlling the bleeding. Then If it is a polycystic ovary, we put them on lifestyle changes. Metformin therapy may be the drug of choice, and depending upon the patient, the younger the age, we put them on cyclical hormones to regularize the cycle along with metformin. And if they desire for fertility, we have to start for the ovulation induction and other tablets. That's how we can. Then. So the abnormal uterine bleeding is a very common condition which can be treated methodically if you come to the proper diagnosis, history taking diagnosis, we can manage abnormal bleeding. Okay. ನೋಡಿದ್ರ ನೀವು ತೆಗಿಯೋದು ಹಿಂಗೆ ನಾನು ಅನ್ಕೊಂಡೆ
Question ಬರ್ತಿದೆ.
ಹಾಂ
Question
ಯಾ How do we understand that the bleeding is abnormal? If the bleeding is more than 7 days, and if there is a history of clots, and also if it is irregular cycles, less than 21 days, more than 35 days, and also if it is intermenstrual bleeding, we call it as abnormal bleeding. So it should not happen intermenstrual bleeding. And if the bleeding is more than 7 days, and if there is history of clots and associated with severe painful period, we call it as abnormal bleeding. Second question is the lower abdominal pain followed by heavy bleeding can be a symptom of, yeah, definitely it is a case of suspect. Usually the lower abdominal pain with heavy bleeding, commonest will be it could be a fibroid polyps or adenomyosis. Mm. Can this cause irregularity in period? Definitely, it can cause irregularity in period because of the hormonal imbalance, thickening of the endometrium, and the irregularity is common, less than 21 days and more than 35 days it can. Can it be treated completely? Depending upon the age group, we can decide the management, starting with the tranexamic acid and progesterones for short cycle, and then oral pills for short course of 2 to 3 months. And if there is a local cause like polyp that can be removed by hysteroscopy, and if there is a fibroid, if they decide to conceive, keep the fertility, we go for only myomectomy. If the patient has finished the family, we can think of hysterectomy. 4 questions I got it. Astella, yeah. ಏನು ಮಾಡೋದು? Can this be treated completely? Yeah. ಎಷ್ಟೊತ್ತು? ಒಂದು 5-10 ನಿಮಿಷ ಆಯ್ತಾ? ಇದು ಸ್ಟಾಪ್ ಮಾಡಲ್ವಾ?
Hello? Chitra? Chitra? Yeah, all questions completed. So what is session, close the session? So if you can audio, like audio with that will be better. You can enter the session and you can ask the question directly to the person. That will be better. Okay, okay, then we'll be waiting for another 2 3 minutes. Just let me know any question will come. Okay, fine. Okay, after that we'll wind up. One question will come.
Yeah. Yeah. Post treatment, can it recur? Definitely, because sometimes if there is no improvement with progesterone, we have to shift to the oral pills. If there is a local cause that needs to be treated, if it is treated, I think the polypectomy it should not recur. If it is due to fibroid, normally it doesn't recur. There will be completely, it can be treated. If we treat the proper cause, no, then definitely it will not recur. Like polypectomy, myomectomy, and like, sometimes with adenomyosis, they keep coming with heavy bleeding and all that. Then we have to think of alternative management in adenomyosis. Like if there is no improvement with the levonorgestrel, we have to go for hysterectomy depending upon the age and patient acceptance. If there is a symptoms, if there is heavy bleeding, not controlled with merina insertion. ಅಷ್ಟೇ 4 can this be treated? One. I am 40 with irregular period and my myomectomy 10 years back. Is it menopause? I am 40 with irregular periods. So probably perimenopause, no? The now whether a recent scan has been done, we have to see, or whether any fibroid has recurred or what. And sometimes it could be. Are you having irregular period? That is a perimenopausal. Their irregularity is normal. We have to look for any scanning, no? Any fibroids are there again. And it could be a part of premenopause, no? The irregular cycles is normal before menopause. And better in ultrasound, any reason? What severe level it can lead to? So sometimes it's so severe that patient can go into severe anemia and severe blood loss and hypovolemic shock also. And we have to correct her anemia, arrange for the blood, and sometimes we have to treat the fibroid and polyps. Um, we are improving anemia, we have to go ahead with the proper treatment like polypectomy and myomectomy. Sometimes it can lead to severe anemia and hypovolemia, arranging for blood, arranging for the improvement of anemia, correcting her any other hormonal imbalance like thyroid, control of any sugar, all that it needs. Prevention is so that early detection, no initial cycles, if it is any abnormal bleeding, better to meet the gynecologist so we can diagnose it early, like regarding any coagulation disorder, any fibroids, any polyp. So we can prevent that severe anemia going into, no. So diagnosing early and treating properly, timely intervention of tranexamic acid, progesterone, and giving oral contraceptives. Depending on the age, we can decide the management. To start with, we can give the tranexamic acid. Then progesterones also help to control the bleeding to prevent severe anemia going into hypovolemia that. And we can later decide for the proper therapy. After doing an ultrasound, coming to the conclusion, diagnosing about what is any fibroids or polyps or any adenomyosis, then we can decide the management. Definitely, lifestyle will help, the reducing the obesity itself will correct the hormonal imbalance. Sometimes stress, then lifestyle changes, they have to avoid putting on weight. And nowadays it is very common, then too much lifestyle easing, causing hormonal imbalance, the obesity, which could be due to the change in the lifestyle. So the daily, workout, walk, diet, exercise, change in the lifestyle is the most important. Reducing obesity, correcting, thereby it will correct the hormonal imbalance. So we can control the abnormal bleeding by good lifestyle changes. These abnormal medicines can, especially we cannot give oral contraceptive for longer duration. If the patient is obese, having hypertension, diabetes, we cannot give oral medicines, oral contraceptives. Definitely, we should monitor the patient blood count, other parameters, no, the liver function test, sugar, then her obesity itself. We cannot give the oral contraceptive for long time. So only a short course, and progesterones can be given, which is better than the oral contraceptive, especially if the patient is having obesity. And the younger the age, we have to go more for progesterones. The if If the patient is having more than 45 years abnormal bleeding, so first line of management will be the short course of progesterone and deciding for the endometrial biopsy, ruling out the pathology like endometrial hyperplasia and things. The mental health, because they become so desperate because of the heavy flow, that will affect their social activity and severe anemia. They cannot do the regular work. That definitely affects the mental health. So prevention is very important. So they can come for a regular gynecological checkup in case any abnormal bleeding, rule out the pathology existing, and timely intervention of giving the medications. Definitely, it will improve their mental health so that they don't go into the severe anemia and other side effects. Especially the menopausal age, we have to treat it early by this thing, rule out hyperplasia and decide for the hysterectomy. How often can we check the post medication? If they're on oral medication, every 3 months they have to come. If it is in Marina, that is the insertion we use for adenomyosis, and then the levonorgestrel, every 6 months is important for the follow-up. And hysterectomy, we just ask for a post hysterectomy, we ask for immediate 1 week and 1 month follow up. And if ovaries are removed, we ask for HRT and all that. They have to come every 6 months. If they're on contraceptive pills, 3 months. Progesterone also 3 months. ಅಷ್ಟೇ ಬಂದಿದೆ. Can often should we get ourselves checked post medication? If they're on hormone contraceptives, every 3 months better. But norgestrel, that is levonorgestrel, every 6 months. And especially if it is this thing, no, post surgery, well, HRT and all that. And if it shows, this is all the question, doctor. Over. I Yeah, we can close the session. Yeah,
Can
put.
wait for 30 seconds.
Yeah, yeah, no problem. One picture ತಗೊಳ್ಳಿ. I want to give it to my